Going live. Good morning, everyone. Hope you're having a lovely Thursday morning. Dr. Randall Gates, board-certified chiropractic neurologist, also a chiropractic physician at Gates Brain Health. I'll just say it one more time because the stream started at different times. Dr. Randall Gates, board-certified chiropractic neurologist and also a chiropractic physician at Gates Brain Health. And so today I am talking about celiac disease, why gluten destroys your body if you have celiac disease. That's a demonstrative title, and I'm not meaning that if somebody does not have celiac disease. So I did a short broadcast a couple nights ago about some of the causes of celiac disease, why it's more common now, also some of the historical features that celiac patients are going to experience. And in today's broadcast, we're going to go a little bit deeper. We're going to try and delve into the detailed physiology of celiac disease. So if you just want an overview video, a short one, the one I did a few nights ago, probably the one you want to watch, but today's is going to be more in depth. For those of you on Facebook, go ahead and send me any of your questions, and I will try to look at those as I go through the broadcast. Okay. So this is the article I'm largely going to be citing. It's the best one I found in recent time regarding celiac disease. They're talking about non-celiac wheat sensitivity as well. In this article, I just focused on the celiac disease component, but this is an open access article from Frontiers in Nutrition, and all of you can go out and find this, and it's pretty interesting. So okay, so moving on. So defining celiac disease. So what is celiac disease and how is it different from what most of you would consider a gluten sensitivity? Celiac disease is where there's an actual autoimmune component. Autoimmune means your body is attacking yourself. Examples of autoimmune diseases would be type 1 diabetes, Hashimoto's thyroiditis, multiple sclerosis, lupus. If you've known anyone with those conditions, you probably realize how severe or significant autoimmune disease can in fact be, because literally the immune system, which has millions of checks and balances to prevent our own antibodies and T cells and B cells from turning on us, some of those mechanisms break down in autoimmune disease patients, and when that happens, as a consequence, our tissue gets destroyed. And whether it's your pancreas, whether it's your thyroid, whether it's your brain and the spinal cord, whether it's your peripheral nerves, whether it's your kidneys and your lungs, it is not a fun process. And celiac disease is an autoimmune disease, and what triggers it is the ingestion of gluten. Gluten is a protein in wheat, barley, oats, and rye, and it's fairly ubiquitous. So most foods in our contemporary society here in America are processed. They contain gluten-rich foods. So your breads, your pastas, your cereal grains, your bagels, your corn dogs. I mean, it just goes on and on and on. Gluten's in soy sauce, gluten's in beer. Gluten is in a lot of different foods that we consume. Now, for celiac disease patients, different from someone who has a gluten sensitivity, when a celiac disease patient eats gluten or ingests gluten, literally their immune system starts killing their small intestines, basically. And so they call it an enteropathy. But as I mentioned in the broadcast a few days ago, in celiac disease patients, there's a lot of other extraintestinal manifestations, maybe joint related, maybe skin related, oftentimes neurologically related. So we'll get into that as well. So what is celiac disease? Defining it, it's an autoimmune disease characterized by aberrant response to gluten in genetically susceptible individuals. Because it is an autoimmune disease, there is a genetic component. The HLA-DQ2 and HLA-DQ8 variants basically predispose someone to that. What does that mean? It just means you have, basically we have these things called antigen presenting cells. And antigen presenting cells help us to recognize foreign invaders. And some people have these different HLAs on their antigen presenting cells, which may make them more likely to have an autoimmune disease. So the classic is ankylosing spondylitis, where literally the spine fuses. The spine becomes like a rod. And with ankylosing spondylitis, there's an HLA-B27 genetic risk factor. For rheumatoid arthritis, I think it's HLA-DR4. For celiac, it's HLA-DQ2 and DQ8. It just goes on and on, depending on the autoimmune disease. But there is a genetic component. The question broached in Tuesday night's video was, why is it so much more common now? Why is celiac disease more common? Because the estimated worldwide prevalence was 0.02%, I believe, in the 19th century, whereas now it's 1% of the population. And initially, researchers thought, well, it's just that we're more aware of celiac disease, and that's proven not to be true. Celiac disease is on the rise. I think it's doubling in prevalence every 20 years or something crazy like that. And most researchers seem to think it's not that we're ingesting more gluten than, say, we did around 0 AD, because they were eating a lot of gluten then. Most of them think it has something to do with a change in the microbiome, the 37 trillion gut bacteria that we have in our intestines. It seems that the current environment, whether it be lots of antibiotic administration, something in our water, or maybe it's changes in how our food is produced, those things are leading to an abnormal microbiome, which is making us more susceptible to a variety of autoimmune diseases, not excluding celiac disease. So that is how celiac disease is defined. And then, why is celiac disease increasing? I addressed that. How is it developed? And that's what I'm going to go into now. So for those of you who really like the nitty-gritties of some of these presentations, and good morning to everybody who's joining. This slide is fantastic. You can pause on this slide if you want to read through this. This is also really, really good information regarding what I'm going to talk about. So how does celiac disease develop? And let me see. Excuse me 1 second. See if I can get my chapstick. It has just become very cold in Nevada, and we have our dry weather. So, and for those of you on Facebook commenting, I'm with you. Yes, it is thought that maybe some of the pesticides used in our foods may be affecting the microbiome, but that is not for sure yet. So, gluten. Gluten is known to be a tough molecule to break down. And hopefully it's not too bright in the background now that the sun's coming up. But gluten is known to be a tough molecule to break down. It is thought to be tougher now than it used to be before. In fact, they're using different pesticides more frequently now. They're spraying them on the wheat crops to help with the harvest of getting more and more yield of wheat out of the crop. So with that, gluten's a tough molecule. Maybe it's tougher now with how we've hybridized wheat. A lot of people say, well, wheat is GMO'd. To my knowledge, wheat is not largely GMO'd at this point in time. Other GMO'd crops are things like tomatoes, corn, soy, and I'm not going to be anti-GMO on this broadcast, but I'm just addressing what a lot of you are reading and a lot of you are thinking. Nonetheless, we ingest gluten. It's tough to break down in the intestines. So as a result, we get gliadin peptides. So the gliadin molecule does not break down into amino acids, it breaks down into peptides. So it's functioning as a protein. And proteins can elicit autoimmune responses. So the gliadin peptide comes in, and then we're going to have basically a variety of things happen. Intraepithelial lymphocytes, so these are just immune cells, in your small intestines are going to increase if you have celiac disease, because these lymphocytes are going to say gluten is a bad guy, these gliadin peptides are bad guys, we don't like them. And then when that happens, we then can get a variety of things occurring, like neutrophils which neutrophils generally, they're a type of white blood cell that kill bacteria most generally, but neutrophils will come in and they're going to see that gliadin peptide, and they may even evoke responses to kill our enterocytes. So enterocytes are basically these cells you see lining the the intestines. And so neutrophils may evoke changes to damage these enterocytes, because neutrophils, they literally, they're going to kill things like bacteria. And so that's apoptosis. So just, so that's pretty demonstrative. And then we have this CXCR3 receptor, which can bind with gliadin peptides rather, and that leads to excessive expression of zonulin. What is zonulin? Zonulin is the protein complex that binds each intestinal cell together. So you see here, for those of you watching on YouTube, you see that the intestinal cells are bound together. But in zonulin, occludin does that. But what can happen is you can have an increased expression of zonulin in this type of situation, and then it's like the zipper opens up. When the zipper opens up, now we have gliadin peptides coming through into the bloodstream out here. And so now we're going to have some immune contact. And basically, once the gliadin peptide gets out here, we are going to have the transglutaminase enzymes go into effect. And then that complex then can lead to your antigen presenting cells. And if you have celiac disease, genetic risk factors, HLA-DQ2 and DQ8, these antigen presenting cells are going to see this gliadin transglutaminase complex and freak out. And then that's where T helper cells are going to basically further differentiate, and we're going to have production of autoimmune type profiles. Celiac disease is known as a Th1, Th17 imbalance. You may have heard me talk about Th1, Th2. Generally, Th1 is one side of your immune system. It's like kind of like the Marine Corps. It does the face-to-face combat with bacteria and viruses. That's too dominant. Th2 is when the Air Force side of the immune system tends to be too dominant, basically. So celiac disease is a Th1 dominant illness. Now that this antigen presenting cell, which is already has a proclivity for creating a celiac disease type response, now is driving Th1, Th17 responses. B cells get involved, and we produce antibodies. Gliadin antibodies, we produce tissue transglutaminase antibodies. If that was too much, maybe go back and rewind and watch this over again, look at this diagram, but that is the physiology of celiac disease, and that's really important. If you have celiac disease and you really want to understand it, it's important that you know this, because this explains your condition. And if you want to have a more in-depth understanding than just gluten's bad and gluten causes celiac disease, this is what's occurring. And this helps you to understand the blood tests that doctors use in terms of diagnosing celiac disease. So is it hereditary? Yes, it is. Not 100%, but yes, it's hereditary. Symptoms of celiac versus non-celiac gluten sensitivity. So basically, non-celiac gluten sensitivity is when individuals eat gluten and they don't feel well. The way it's diagnosed is you stop eating gluten for 4 to 6 weeks, and if you feel better, then you have non-celiac gluten sensitivity. Some non-celiac gluten sensitivity patients are going to have antibodies to gluten. They generally do not have the diagnostic findings of celiac disease in terms of the positive tissue transglutaminase, endomycel antibodies, tissue transglutaminase antibodies, endomycel antibodies, and the duodenal biopsy features. So, and I think what tests determine celiac disease and is it misdiagnosed. So the tests used to determine celiac disease are exactly what I just mentioned. So we have blood tests. Blood tests can include tissue transglutaminase antibodies, endomycel antibodies. Gliadin antibodies may or may not be positive. And those are the blood tests. You can also have the blood tests for the genetic predisposition. Doctors will often run those. Now, on the tissue transglutaminase, what they have found in terms of those antibodies, if they are 10 times higher than the upper range of normal, then it's thought that you may not need a duodenal biopsy by some researchers. That is not the gold standard at this point, but I'm just giving you what's in the literature. In 2015, an article came out in the journal Pediatrics, I believe, maybe it was Pediatric Gastroenterology, where they looked at, okay, these young individuals were eventually diagnosed with celiac disease. What were their initial blood markers? Can we predict based on the blood markers what the small intestine is going to look like? And in essence, they found that if your tissue transglutaminase antibodies, in this case, if they were 10 times too high or above that, Then they saw no reason to do the duodenal biopsy. Now the duodenal biopsy is still part of the gold standard workup, and as you can see in this diagram, this is basically what the duodenum looks like in a celiac disease patient, or what's going on metaphorically. And so they go in and they take out a piece of the small intestine, they look at it under a microscope because they're looking for characteristic features. What are those? Increased intraepithelial lymphocytes. They're looking for villus atrophy. These little finger-like projections of these enterocytes are called villi. The depths down here are called intestinal crypts. So they see blunting or villus atrophy, and they see increased depth of the intestinal crypts. And those are the main things they're going to see. And there's something called the Marsh criteria, which is where, based on how much villus atrophy, how bad the intestinal crypts are, how much intraepithelial lymphocytes you have, that will constitute these different levels of the Marsh criteria and how bad the celiac disease truly is. So that's why this diagram I present, for those of you on Facebook, go back and watch the YouTube broadcast, because it's pretty cool. Okay, and then I think I skipped over this. The classical symptoms, I think it's just important to go over this. The classical presentation are gastrointestinal symptoms, diarrhea, malabsorptive manifestations, constipation, and abdominal pain. As I mentioned a couple nights ago, basically those who are diagnosed with celiac disease in childhood are more likely to have gastrointestinal symptoms. Adults can be diagnosed with celiac disease, and certainly what we're finding is that as people become older into the 4th and 6th decades, that they can still be diagnosed with celiac disease, and oftentimes they more have neurological problems. Like 30% of them are going to present with neurological problems, not necessarily gastrointestinal problems. So just because you don't have GI symptoms doesn't necessarily mean you don't have celiac disease if you're an adult. So treatments, can it be completely healed? So the treatment is adherence to a gluten-free diet. But as researchers have shown, that adherence to a gluten-free diet can be as low as 36 to 45%. So these are individuals with celiac disease, and they're not maintaining their gluten-free diet. It may lead to one scratching their head. And basically the excuses are with limited availability, high cost of gluten-free products, and social isolation being raised as a main causative factor of this poor adherence. So, this is an issue that I know I've dealt with for a long time. I've talked with other professionals who, patients may relay, I'm not really on the diet, or I cheated. It's just diet has such a pejorative connotation in our society. It's not good. And so I don't know. There's something about the psychology of it being so difficult to take gluten out of the diet. And then, in terms of limited availability, I would say in today's day and age, it probably depends on where you live. I've seen patients from many different parts of the world and many states in the U.S. And basically, when they come and see me, we talk about what's available in their local town. And sometimes there aren't a lot of gluten-free products. But now with the advent of so many things can be shipped, the excuses, the legitimacy of the excuses, I think, are going down. Are they more expensive? They are a little more expensive. But also, you don't have to eat gluten-free bread. You can just eat, what you would have ate without bread. That's another option. But it is more difficult, and there is the social component where, you may be at Thanksgiving dinner and Aunt Betty made you your favorite pumpkin pie, and you're sitting there with celiac disease or gluten sensitivity thinking, should I eat this or should I not eat this? And so, those are the questions you have to answer yourself. But just know that a lot of celiac disease patients where there is an autoimmune component to gluten are not staying on their diet. So adherence may be as low as 36%. That's like 2/3 of people are not on the diet, not on their gluten-free diet. So there's this other thing called refractory celiac disease, which is where, you may be on a gluten-free diet and still not feel well. That's not completely uncommon. And there's 2 types of it. And one is basically, if you stay on the gluten-free diet, by 5 years, you're going to be healed, but you just have to be patient. The type 2 refractory celiac disease, it can take 5 years, and only half of those individuals are going to feel better. What would I argue? I'd say you probably have other food sensitivities, and that's my experience, and you probably want to really be doing something to heal your intestinal permeability. Are gluten-free products actually gluten-free? Most of the time they are. There's a lot of discussion online about this. Just keep in mind that doctors employ content writers who may not have all the facts all the time. And so there's a lot of misinformation, in my opinion, out there. If something says that it's gluten-free, it's certified gluten-free, they have gone to great lengths to make sure it's gluten-free. So I would trust that if it says certified gluten-free. If it doesn't say certified gluten-free, then proceed at your own risk. And I have some other references. I have some patients who have really delved into this, and they're great references on this. So if any of you have questions on how to navigate that, just let me know. And then, can a celiac disease person ever eat gluten again? Here is what is being discussed in the literature. Endopeptidases basically are molecules that are designed to break down gluten. Those are being employed. These are basically like gluten enzymes, so like gluten-ese, I believe, is an endopeptidase. Gluten sequestering polymers, tight junction modulators. I think one is laurositide acetate, if I'm pronouncing it correctly. Yeah, laurositide acetate. So they're looking at different medications to help the zonulin and gluten complex stay together. Transglutaminase 2 inhibitors, immune therapies. So those of you who are familiar with the term biologics are medications. They're typically antibodies that target other inflammatory immune cells in our system. You may have heard of Enbrel, you may have heard of Ocrevus, you may have heard of Humira. Those are probably the most popular biologics, monoclonal antibodies out there. And so now they're looking at biologics for celiac disease. Why? Because these biologics are expensive. Companies are going to make a lot of money on them. And if only 2/3 of the celiac disease population is actually, no, if only 1/3 of the celiac disease patient is actually adhering to a gluten-free diet, there are a lot of people out there not adhering to the diet, which is going to lead to a rationale why they should be on expensive medications to control their symptoms. Necator americanus are looking at hookworms for celiac disease, trying to get the immune system to fight the parasite rather than fighting the intestines. Nanoparticles, they're looking at a vaccine for gluten, and probiotics. The probiotics may help symptoms. None of these yet have really shown to lead to what you would consider as a cure or a significant change, but research is being done. Can a celiac diagnosed person ever eat gluten again? I would say no. And why would you want to? It's literally, gluten is causing your immune system to kill your small intestines, and gluten is causing other issues, as I mentioned, in adults. Lots of times neurological symptoms, literally the cerebellum degenerating, literally peripheral nerves being eaten away by the immune system with the ingestion of gluten. And celiac disease patients, very, very serious. So that would be my take on it. So it's not just that the intestines are affected. Joint pain can occur, skin can be affected, dermatitis herpetiformis, and these neurological problems, even the association with depression. So that's why I say celiac disease patients should never eat gluten. So thanks for watching. Again, Dr. Randall Gates, board certified chiropractic neurologist and chiropractic physician at Gates Brain Health. If you have any questions on this detailed broadcast, let me know. There's our email, info@gatesbrainhealth.com. There's our number. And thank you all for watching, and have a lovely Wednesday.